Hi guys, welcome back. The next topic that I'm explaining to you is channelopathies, which is relatively a rare cause of development of weakness in a patient. Well, you can see the basic infrastructure here. I've shown a nerve, muscle, neuromuscular junction, and the black dot that you can see here is actually a sodium channel by the name of SCN4A. I would like to refresh your memory by reminding you the fact that in cardiology, I've spoken about SCN5A, the defect of which results in Brugada syndrome, which can cause sudden cardiac death. But today, in the neuro part, I'm going to describe a channel which is going to be located on the skeletal muscles. And now let us see what can be the problems anticipated with this. First of all, I want to point to the fact that if there is going to be a loss of function, I'll describe in fact two domains. One is a disease where there's a loss of function, second where there's going to be a gain of function. Let's take focus first on loss of function. Well, the problem will be that there's going to be less sodium going inside the muscle, and that means that there would be a defective depolarization, and that makes sense that why is there's going to be a weakness, because the amplitude of contraction per se will definitely be hampered in this case. At the same time, because this channel is responsible for sodium going inside and potassium coming out, so if less sodium will go inside, less potassium will come out also. That is why the name of the disease that I'm writing here before you would be called as hypokalemic periodic paralysis. I will also explain to you that why are you calling it periodic per se. But first of all, I just want to highlight that why is this disease called as hypokalemic, why the nomenclature is like this, because you can see that if there's going to be less sodium going inside, less potassium would be coming out. So there are two problems in this patient. There's going to be defective depolarization as well as a defective repolarization, and the end result of this would be that the muscle will not be able to perform like normal, which explains the weakness of this patient. Now, let us say why this patient would come to you. In fact, the clinical presentation of this disease is very peculiar in a sense that the patient will say that after eating my breakfast, I feel as if there is no energy in my body. You see, it's not only breakfast, it could be lunch, it could be dinner. Now, I understand that if you have a heavy meal, you can feel sleepy. This guy is not saying that I feel sleepy after a heavy meal. He says, I feel as if there is paralysis of my body. I feel as if I'm not getting breath. So initially, when this patient came to me the first time, I thought that he's bluffing. He's malingering. He's just telling me that I get weakness after eating food. I mean, it's understandable that after eating food, and especially a heavy meal, carbohydrate, fat-rich meal, you tend to feel a little groggy, a little lethargic. But this guy is saying, sir, I can't even breathe. So I thought I should refer him to the psychiatrist. But before I did that, we all doctors tend to have that sixth sense always going, that before we say that this is a functional disorder, we need to rule out a medical disorder as well. So this guy was basically highlighting the fact that carbohydrate rich diet is triggering the weakness. So I evaluated what could be the possible reason, and this is what I could fathom, and this is what the textbook says. You see, when you eat carbohydrate rich diet or any kind of meal, obviously the insulin levels in the body will rise, and the point is that insulin causes potassium to go inside the cells, no? And if somebody is having a disease by the name of hypokalemic periodic paralysis, why periodic? Because every time he has a meal, he has a weakness. And at the same time, every time there's going to be a spike of insulin, potassium will go inside the cells. And if potassium will go inside the cells, therefore the weakness of this person will be worsened. In fact, I want to highlight that this person will always be having a defective muscle function. The reason I explained was defective depolarization and defective repolarization as well. The point is that mealtime is going to worsen that weakness. So most of the time, the patient will perceive this weakness at and subsequent to a heavy carbohydrate rich meal. So initially, there is a high index of suspicion that is required to suspect this disorder. In fact, I can say that you straight away can't think that somebody is having a hypokalemic periodic paralysis. Obviously, as I have highlighted to you, even in my discussion of amyotrophic lateral sclerosis and motor neuron disease, that every time a question talks about weakness or a patient talks about weakness, you must always rule out electrolyte imbalances. So I did a serum potassium in this guy. Now the possibilities are that either serum potassium will be normal or will be low. In fact, during the attacks, at that time, post-meal, when he's having weakness to the level that he can't even breathe, at that point of time, potassium levels can be less, but otherwise it can be normal as well. So serum potassium can't be used as the best test for diagnosis of this condition. I thought, okay, maybe he could be having myopathy, so I decided to get a CPK-MM done. That was normal. The nerve conduction velocity was also done to rule out a neuropathy. It was also normal. You see, my thought process is neurოპathies, myopathies are more common a cause of weakness as compared to channelopathy, so I'm trying to rule them out. However, when I did an electromyography, I had to actually evaluate the report with a lot of caution, because if I just draw a crude sketch like this just to explain how things are, if you take this to be a contraction of muscle of a normal individual with a smooth depolarization and a repolarization, the problem in a person of hypokalemic periodic paralysis will be a less amplitude of contraction because less sodium is going inside. So not only I have highlighted on electromyography a defective depolarization but a defective repolarization as well. So electromyography in this patient will definitely show a recording which will be different from normal. I can just say the word, sometimes the word myopathic pattern can be written. Obviously, I'm not saying that electromyography is diagnostic of this condition, because per se this disease is not in the muscles. It is just that the function of the muscles is not performing well because the channels are not working fine. And well, there is no specific test by which you can identify whether a channel is gonna be functioning normally or not. So I want you to remember that the pattern of inheritance of this disease is autosomal dominant, and in fact, had I started with genetic basis, then it would have been easier for you, because even the father of this guy or the mother of this guy could be having the same problems. The best test to confirm the diagnosis of this disorder is a combination of the aspects that I said. Rule out electrolyte imbalance, rule out neuropathy, myopathies, evaluate the EMG of the patient with caution, do genetic linkage studies, and then comment on the diagnosis. And in fact, one of the good ways to actually identify this disorder is also to advise this patient to reduce the intake of carbohydrates to minimal. You will notice a dramatic increase in the general well-being of the patient. I'm not saying that I'm going to cure the patient. General well-being of the patient will improve the moment he will cut down on the carbohydrate component. And anyway, I will have to treat this condition also. Well, there's no drug of choice for this condition. During the episode of weakness, we can give potassium chloride orally. The brand name of that is Potchlor. Lots of time you might have written this brand for your patients of congestive heart failure in the recovery phase. You see, when a congestive heart failure patient presents with acute pulmonary edema, you have to give him Lasix, thiazide group of diuretics, and furosemide. Both of them are notorious to cause hypokalemia. In fact, when you treat pulmonary edema aggressively, hypokalemia will invariably be seen. And to correct this hypokalemia, you give oral Potchlor to patients of heart failure in the recovery phase so that, well, the potassium values can come back to normal. In this case, again, I'm giving a potassium supplementation during the acute attack. So do remember that this is not the cure for this patient, and anyway, we do not have any permanent cure, because if a channel is not functioning due to genetic reasons, we cannot actually manufacture a new channel which starts performing just like normal. A drug that can be used in this condition for preventive aspects is acetazolamide. Now this, when I describe, a lot of students, they come to me and they say, sir, acetazolamide is a diuretic, it will contribute to hypokalemia. So how is it possible that it will cure this patient? Well, let me first explain what the textbook says, and then I think you would be more convinced about what I am saying. You see, he says that acetazolamide actually acts on the potassium channels also. It says that it opens the calcium activated. In fact, just look at the language that I'm writing at the moment. So it says that it opens the calcium activated potassium channels. In simple English, that basically means is that it improves potassium conductance. You see, potassium was not being able to come out of the muscles. That is why the word was hypokalemic. So if you improve So if you improve the potassium conductance of this patient, then the chances of symptomatic relief in this patient can definitely be obtained. And because this is a very surprising disorder where a channel is malfunctioning, so they did a lot of research on this topic per se, and they found out something even more interesting. You see, you are aware that calcium is also released from sarcoplasmic reticulum inside the muscle, and then this calcium helps in binding of actin and myosin and causes muscle contraction. So there is another channel which is involved in the pathogenesis of this disease. When I write the word CAL, you can forget C1A3. You can just remember from the word CAL that I'm talking about a calcium channel. Now I'm talking about a gene that basically codes for a calcium channel. You see, this calcium channel is present in the skeletal muscle, and even it can malfunction. So I want you to remember that in this particular disorder, they have found that there is a problem with two channels. The name of the disease is hypokalemic periodic paralysis, but point number one, it is not a potassium channel disorder. It is a sodium channel disorder, as well as a calcium channel disorder. In fact, the word is skeletal muscle voltage gated calcium channels are also defective in this condition. And as I emphasized earlier, what are these voltage getting calcium channels going to do? They are going to regulate the release of calcium by the sarcoplasmic reticulum to help in the interaction of actin and myosin. If this is going to malfunction, Well, the end result would be a defective or a weaker interaction resulting in decrease in amplitude of contraction. Now, because there are two defects which are associated with hypokalemic periodic paralysis, a question from academic point will be that how do we answer in the MCQ, or how do we explain to the patient, are you having a calcium channel defect? Are you having a sodium channel defect? So to resolve this problem, what they did in the 20th edition of Harrison was that they subdivided the discussion of hypokalemic periodic paralysis into type 1 and type 2. So now I want you to remember that whenever this discussion will come, type 1 hypokalemic periodic paralysis, you will say it is a calcium channel defect. On the other hand, if I change the language of the question and I say type 2 hypokalemic periodic paralysis, then it is going to be a sodium channel defect. And if you ask me that, sir, if it is not mentioned like this, type 1 and type 2, what should we answer? So in a multiple correct response scenario, it is calcium and a sodium channel defect. If both are given, the single best response is calcium channel defect. The basic crux of the discussion is that this is a diagnosis of exclusion. When you rule out all other causes of weakness in a person, before you tell a person that I am going to refer you over to a psychiatrist, I want to rule out channelopathies as well, which will definitely have a genetic basis. So obviously, if the genetic basis is given in the question with father and son both having similar kind of complaints of weakness, a bit of idea for this disease can definitely come in. And once he starts talking about channels, things will become relatively easy. Now, whatever I explained here, I'm gonna do the same activity once again. I don't want you to note down the information at the moment, just follow my words. The black dot is the sodium channel SCN4A. By these thicker green arrows, I'm now showing that this channel is working more than normal. Earlier, I was teaching you a disease where there was a loss of function of SCN4A. Now I'm teaching you a disease where there's a gain of function of SCN4A. Because of the gain of function, since more sodium will go inside the muscle, the query from most students is, sir, where is the problem? If more sodium will go inside the muscle, well, that's good news. The amplitude of contraction would increase. I don't dispute that. Fine. You see, the point is, if more sodium will keep on going inside the cell again and again and again and again, so contraction stimulus will keep on coming. But you see, muscle first has to contract, relax, contract, relax. Here the stimulus for contraction is coming again and again and again. As a result of it, because the contraction stimulus is coming again and again, from the patient's perspective, the word would be cramps. Lots of these patients will actually say that I develop cramps in my hands repeatedly, which you might think could be due to electrolyte imbalance, because you read about muscle cramps even in hypokalemia, you read about muscle cramps even in hypomagnesemia. But the disorder that I'm teaching you at the moment, which is again a SCN4A defect, which is exhibiting a gain of function, which is contributing to more and repeated depolarization, is actually called as hyperkalemic. You can see why am I writing hyperkalemic, that if more sodium will go inside, then more potassium will come out also, no? You can see that there is a 1:1 ratio, no? That is, sodium goes inside, potassium is coming in this case. SCN4A activity, right? I'm not talking about sodium potassium pump, guys. I'm talking about SCN4A channel. Now, if more potassium would come out at the moment, so the technical word I'm putting up here is hyperkalemic periodic paralysis. And here I would also like to mention an interesting fact, which is actually not a therapeutic method, but I just want to say that if I ask this guy to eat a lot of bananas, if I ask this guy to eat a lot of carbohydrates, then the symptoms might become lesser, because you see, then insulin will be released once again after eating a lot of sugar rich food, and this potassium coming out of the cells will become relatively lesser, because insulin per se causes potassium to go inside the cells. I have highlighted that in endocrinology section also. Insulin causes potassium to go inside the cells. Here more potassium is coming out. So you are counterbalancing the faster calcium that is coming out by increasing the amount of insulin in the body of this person, endogenous insulin per se I'm talking about. And that could be with the help of a carbohydrate rich diet, though that is not any therapeutic method of treatment. I mean, you are not going to tell somebody eat a lot of bananas and your disease would be cured. Hyperkalemic periodic paralysis is characterized by genetic reasons once again. The problem in this chap is that the muscle is going to be loving to contract. The muscle is going to contract again and again because there's more stimulus. As a result of it, there would be a defective relaxation, or I can say delayed relaxation, because if the stimulus comes for contraction, then the relaxation part will relatively be lesser. So delayed relaxation of skeletal muscle is the actual fundamental problem in this patient, which the patient, a non-medico, might say cramps and weakness. For me as a doctor, however, I'm not going to use the word cramps to describe the manifestations of this patient. The technical term that you need to remember, and that is the precise reason why this disease is being taught to you, is the technical term myotonia. What do you mean by myotonia? Well, to elicit myotonia, you can just shake hands with the patient and ask him to squeeze your hand with whatever power that he has, right? So patient is shaking hands with you, he's trying to squeeze your hand. You will notice that he will be able to definitely squeeze your hand, but when you will say, let my hand go, you first gave him a command, shake hands, squeeze my hand. When you say squeeze, he's trying to squeeze. Now you say, relax your hand. You will notice that in spite of you giving the command, to let go of your hand, you said, okay, release my hand. He will not be able to let go of your hand immediately. It will be as if he will say, sir, I just got a cramp here, I just got a spasm here. This manifestation where contraction was occurring, but because there's repeated stimulus of contraction coming, but the relaxation part is hampered, is what is called as myotonia. And in fact, that is the question that I want you to remember, that myotonia is a presentation of answer is hyperkalemic periodic paralysis. The logic behind this is repeated stimulus or exaggerated depolarization stimulus, so the relaxation part is hampered in this case. Before I tell you the treatment of this condition, which will definitely be a surprising one, I just want to remind you that you are not supposed to confuse this with myoclonus. I have discussed about myoclonus in the epilepsy lecture, where I have talked about involuntary jerky movements in the hands. In fact, I'll describe myoclonus as well. Let me say that I'm eating noodles or I'm eating rice with a spoon. If I am having a myoclonic jerk in my hand, there's a possibility that I'm eating the rice with the help of a spoon, and suddenly the jerky movement might result in spilling of food on the table or maybe on the person who's sitting opposite me. So per se, involuntary jerky movements of the hand, which can result in development of spilling of food or maybe difficulty in buttoning a shirt, difficulty in wearing of clothes due to sudden jerky movement. You know, if I want to button my collar button, then I need flexibility in my fingers to do that. But in this case, if I am having a jerky movement, there's a possibility that voluntary task might be hampered. Myoclonus, which is having involuntary jerky movements in any part of the body, per se, can be found in various disorders. When it comes to infants, I have described myoclonus with respect to salam seizures, which is also called as West syndrome. Then I have described myoclonus for a neurodegenerative disorder related to the altered measles virus, SSPE. A person consuming beef is developing Dementian myoclonus, that is variant Creutzfeldt-Jakob disease, and a teenager having jerky movements which are causing him to get late school is juvenile myoclonic epilepsy, which has a EEG pattern of 4 to 6 Hz. So the bottom line is that myoclonus per se has been discussed in the neurology section with respect to different age groups: infant, 8 years of age, adult person, and juvenile myoclonic epilepsy, as the name suggests, would be adolescent. And you are not supposed to confuse myoclonus with myotonia or with an alternative term called as myokemia. Myokemia would mean fluttering of muscles around the eyes, which they tend to say in Hindi, aankh fadkna, and that's considered to be a bad sign, right? Myokemia is basically ocular muscle fluttering. It is periocular muscle. In fact, I should highlight, not per se ocular, it is periocular muscle fluttering, which can occur because of nervousness, which can occur due to excessive sympathomimetic stimulation, or can be idiopathic as well. So because these are pretty closely matching terms, that is why I thought that I should definitely discuss them with you. And now we will talk about what is going to be done for this guy. Well, you cannot change the receptor per se, but you can definitely reduce the manifestations of this patient by using acetazolamide. The query is again, sir, you said acetazolamide for hypokalemic periodic paralysis. Now, why are you using it in hyperkalemic? Here we use it in relatively higher dosages than what we use in hypokalemic periodic paralysis, mainly to cause hypokalemia. You see, I could have used thiazides also. I could have resulted in usage of Lasix also, but the point is thiazide and Lasix, the magnitude of hypokalemia that they will cause will again result in a much more additional disease developing in this guy. See, the problem in this guy is more potassium is coming out of the cells. You just need to counterbalance that. So if you use too much of aggression by using thiazides or furosemide in this case, you might actually cause worsening of this patient. So acetazolamide has been found to be useful for both of them for preventive aspects. Additional drug which I definitely want you to remember from MCQ domain for especially hyperkalemic periodic paralysis is used in cardiology also. This molecule per se is taught in ventricular tachycardia, though it is not the drug of choice for ventricular tachycardia, but definitely you read about mexiletine in VT, and the same drug has also been found to be useful for treatment of myotonia. So just remember the statement of mine: myotonia is managed with help of mexiletine and acetazolamide, and these are two channelopathies which I want you to remember. One of the important carry-home messages at this junction is that none of these are potassium channel defects. The name is hypokalemic/hyperkalemic periodic paralysis, but they're actually sodium channel defects. In fact, for hypokalemic, I've told you two informations, that type 1 is going to be calcium channel and type 2 is going to be a sodium channel defect. I shall now be teaching you a variant of hyperkalemic periodic paralysis which is called as paramyotonia congenita. As the name itself will suggest, the clinical manifestation that you will encounter in this case would be myotonia once again. The difference from the previous cases, however, is that myotonia or paramyotonia congenita is usually triggered by cold exposure, like eating of an ice cream or maybe going to a relatively cold area. From the exam perspective, you also need to remember that even this condition will be having a gain of function of SCN4A. So that is why I mentioned initially this is a variant of hyperkalemic periodic paralysis. PP would mean periodic paralysis. Because these terms have been used time and again, it's my job now to explain to you what are the diseases of sodium channel per se that I have described before you, what are the diseases of the calcium channel that I have actually explained to you, and this is the main crux of this discussion. The main reason why we are going into this topic per se is to get this table right. The first time I explained a sodium channel defect was hypokalemic periodic paralysis, where there was a loss of function of SCN4A, which was technically called as type 2 variety. The second time I have highlighted this is for hyperkalemic periodic paralysis, where thankfully you don't have to remember any subtypes. But yeah, the pediatric profile of this is called as paramyotonia congenita, where you have symptoms which are usually triggered by cold exposure. In contrast, when it comes to calcium channel defects that I've explained to you, at the moment I have explained hypokalemic periodic paralysis once again, that is type 1. Over and above this, in the earlier part of the discussion, when you listen to myasthenia gravis, I have talked about anti-P/Q antibodies against the calcium channels which are caused by lung cancer, especially oat cell cancer. The disease of calcium channel that I've discussed earlier is Lambert-Eaton syndrome. And just to make it a all except MCQ, I'm adding a detail here which you will be able to find in the migraine and the headache topic, that is familial hemiplegic migraine is also a calcium channel defect. You can see the importance of this table per se, in a sense that he basically wants you to remember these names. Over and above this, in the all except MCQ, there is a distinct possibility that the fourth option, most of the time that I have encountered in previous years for this particular question per se, will talk about episodic ataxia. Episodic ataxia, guys, is a potassium channel defect. I would like you to write it down on a stick-on pad and stick it somewhere so that you can remember these informations time and again. Over and above this, I also want you to remember a chloride channel defect related to muscles. The important one to be remembered is Thomson disease. So when it comes to all except MCQs, either the two informations that I've highlighted could actually be put up in the question. Let me now make you revise the aspects that I've taught you in cardiology for SCN5A defect, which would be related to the cardiac tissues. A quick revision here for Brugada syndrome. In the clinical history, he's not going to talk about a person who's playing football or basketball or doing any kind of strenuous activity. This guy could be sleeping in his bed, or maybe he's just watching a laughter show like Kapil's show, and while laughing, he just died. So when you read about sudden cardiac death, or you read about especially nocturnal death per se, in a Southeast Asian male, he's a young chap, he was previously healthy, and then he just expired just like that, then Brugada is obviously to be considered. Now, what is the problem in this condition is that the sodium influx is defective in the cardiac tissue this time. So there is a defective inward current. Mark my words there, defective inward current in the right ventricular epicardium, which results in development of an electrical gradient. Please remember, we should not be having any voltage gradients between the myocytes. You see, there's a difference between voltage gradient between the inside and the outside of any particular cell or per se of a cardiac myocyte. But if there's going to be voltage gradient between the myocytes per se, then it's going to be like the voltage terminals of a car battery. Like you have a positive terminal, negative terminal in a car battery, you short them. There's going to be sparking. Similarly, in this case, because there's a voltage gradient between the different myocytes, all myocytes are at different resting membrane potential. So the short circuit that develops in this condition due to this voltage gradient results in development of ventricular tachycardia. There is a possibility that this guy whose elder brother had died suddenly came to you. He says, sir, I'm okay, but my brother just died suddenly, so I thought I should go and see a doctor. Or he might say that, like my elder brother, I also have a tendency to become unconscious at very frequent intervals. Suddenly, no workup has shown any abnormality. But when you carefully see the ECG of this guy, per se, whose elder brother had died suddenly, elder brother had syncopal attacks, no doctor could pick up any abnormality, the elder brother died, this guy is hell scared. He says, sir, I don't want to die like him. When you look at the ECG carefully, there is a possibility that you might be able to pick up the ST segment elevation in this particular case, which is called as the Cove pattern. In fact, the various kind of ECG abnormalities that can be detected in Brugada syndrome are discussed in the cardiology section itself. But I just wanted you to refresh your memory for the fact that if it's going to be a voltage gradient with respect to the skeletal muscle, we were talking about disorders like hypokalemic and hyperkalemic periodic paralysis, whereas in cardiology, it is going to be rather Brugada syndrome, and family stress sudden cardiac death, if given, will help in diagnosis of this case. Now, in the same spirit, like I was teaching you a potassium channel defect with respect to skeletal muscles, I'm now going to teach you a potassium channel defect with respect to cardiac tissues that is called as Anderson-Thavi syndrome. I repeat the statement once again. Earlier, I taught you a potassium channel defect with respect to skeletal muscles, episodic ataxia. This time, the word is Anderson-Thavi. And because even in this condition, there is a high risk of sudden cardiac death, so implantable cardioverter defibrillator is the treatment of choice. Indications of ICD have been discussed in the cardiology section, so you can go through that there, but you can add this word Anderson-Thavi to that as well. I shall now be explaining to you regarding how to differentiate between weakness of a neuropathy patient versus that of a myopathy. So there will always be some keywords that will help you in differentiating between the two, so that you can order the appropriate investigations for the final diagnosis of the patient. You see, per se for neuropathy, he will usually talk about a distal muscle weakness. Now, what I am saying next is not an absolute rule that it's always going to be a distal weakness, and for myopathy, it's always going to be the proximal muscle weakness, but this is the usual presentation. So there would be certain terminologies used by the examiner which will help you in differentiating between the two. When I say distal weakness, the weakness would be mainly with respect to the wrist joint or for the ankle joint. So if you do activity like this, like turning on the ignition key of your car or turning a doorknob, that will definitely be a troublesome aspect for a person with neuropathy. Most of the time, neuropathies are acquired and myopathies are going to be having a congenital origin. But you see, that can't be used as a differentiating feature. It is words that I'm writing now which will help you in identifying the question what kind of disease is he talking about, a neuropathy versus a myopathy. If he says difficulty in turning a doorknob, or he talks about difficulty in turning on the ignition key of a car or a bike. Similarly, there can be weakness of muscles around the ankle joint. So therefore, there can be recurrent falls on slippery surfaces. Like in foreign countries, when it snows, there could be ice on the road. When this person is walking, he is having a tendency to slip again and again and could end up with injuries as well. So recurrent falls and foot drop would be present in this patient. In fact, with the foot drop present, when the foot will strike the ground, it might even be referred in MCQs as slapping it. So these are the kind of terms that you need to look for in the MCQ to identify a neuropathy. In contrast, when it comes to a myopathy, I have described even in Cushing syndrome topic, difficulty in climbing stairs. So I usually find people not having any difficulty in identifying a myopathy. So that's why I started with a neuropathy. You see difficulty in climbing of stairs, or per se, if shoulder girdle weakness is present, then ability to raise the arm above the level of the head, like difficulty in combing of hairs, is going to be read by you with respect to myopathy. Now, apart from this, additional information that can help you would be neuropathy patients will be having a areflexia. But if muscles are damaged, like in any kind of a myopathy or Duchenne's muscular dystrophy, you will notice that the reflexes in the patient are preserved. While I'm writing this, please tell me what is the fundamental difference between myopathy versus muscular dystrophy, because both are not the same. The fundamental difference is that in myopathy, the magnitude of weakness will remain the same, whereas in dystrophy, the weakness will progressively increase. I repeat that again. The term muscular dystrophy means progressive increase in muscle weakness. So when I will describe Duchenne's dystrophy to you or Becker's muscular dystrophy to you, I will mention that the weakness will increase and the child will become wheelchair bound. But in myopathy, the muscle weakness will remain static in its course. Additional fact which will always help you in differentiating between the two would be that nerves are responsible for both motor function as well as sensory function. So if a person is going to be having a neuropathy, there's a distinct possibility that in the question he might actually make it very easy for you by writing the word glove and stocking anesthesia. Whereas when it comes to muscles, they do not have any role in sensory function. They are purely for motor function per se. If you are still in doubt, you have investigations at your disposal. For a neuropathy, the test that you have is nerve conduction velocity, or you can even go in for a nerve biopsy. Now, nerve biopsy, what nerve would be used for nerve biopsy? Because you see, if I do a nerve biopsy, I'm damaging the nerve also, so the motor function would be lost. I don't want a motor deficit after my procedure. So usually the nerve that will be used will be sural nerve, but you are aware from the discussion of leprosy, which the dermatologist would have also talked about and could be talked in other subjects also, that if a person is having neuritic subtype of leprosy and you are planning to do a nerve biopsy, then this would be done from the ulnar nerve. In fact, if in the questions he has mentioned superficial branch of the radial nerve, then the first answer would be superficial branch of the radial followed by ulnar nerve for the neuritic variety of leprosy. You see, I agree leprosy is a clinical diagnosis, but ideally we should do a biopsy. We do at least a skin biopsy for diagnosis by which we can determine the bacteriological index and then find out paucibacillary versus multibacillary and then initiate treatment. So nowadays the treatment for both of them is same, right? For pauci it is 6 months, for multibacillary it is 3 months, but the number of drugs used is same for them. I just wanted to highlight that in leprosy per se, you are taking a sample from where the nerve afflicted is the one that is going to be biopsied. But if it comes to congenital neuropathies that are described before you, like Charcot-Marie-Tooth disease, then the nerve biopsy will be usually the sural nerve. In contrast, when it comes to a myopathy, what investigations do you have at your disposal? You can be doing CPK-MM levels. They are a very good screening test. You see, CPK-MB is what we talked about in reinfarction after MI after 72 hours. But CPK-MM levels and then a muscle biopsy again would help you in identify that is it a myositis? Is it a myopathy? Because like for example, there could be possibility of neutrophilic infiltration into the muscles in a disease like dermatomyositis and polymyositis. Or I have talked about a disease by the name of inclusion body myositis. So inflammation of the muscles versus the myopathy component versus muscular dystrophy, there are fundamental differences in the biopsy reports as well. So clinically speaking, these are some words that will be written in the question and the laboratory reports will definitely aid you in diagnosis. One of the important causes of neuropathy that I want you to remember and is very frequently asked is diabetic neuropathy. The technical details of that I have mentioned even in the diabetes mellitus part. Here I would like to mention the salient features once again because they're important from the exam perspective. One, I've told you sensory system is the first one to be involved. Then is going to be motor involvement and then is going to be autonomic involvement. Autonomic is obviously bad news and it can even contribute to silent myocardial infarction in the patient. When it comes to what is the sensory involvement, it would be distal sensory loss. If he says which sensation is the first one to be lost in the patient, then the first deficit that is noted or first lost to be answered is vibration sense. So if you are gonna just recall these facts once again, that would definitely do you good for the final exam. When it comes to motor involvement, in fact, that is the reason why I have gone into it, because that is the point we tend to forget, that in diabetic neuropathy, even cranial nerves can be involved. And the highlight of this has been asked in the NEET exam, that though you will get a third nerve palsy, it will be associated with pupillary spinning. On this, the query of most doctors is that, sir, how is that possible? If a third nerve is involved, it is going to be responsible for light reflex also. So why pupillary spinning? The logic is that the fibers which are going to be supplying or fibers that are going to be controlling the pupillary action per se, that is meiosis or metriosis, are more deeper situated. Whereas the fibers which are controlling muscles like levator, palpebrae, superioris and medial rectus are superficially located. So because the superficial damage is more than the deeper one per se, the fibers which are going to control the light reflex per se are relatively spared. So that is why you read this term, third nerve palsy with pupillary sparing, very characteristic for diabetic neuropathy and may also be seen with arteriovenous malformations in the brain, like for example a berry aneurysm. For the autonomic involvement, one I said there could be a possibility of silent myocardial infarction that could actually cause expiry of the patient, or they could be orthostatic hypotension, which could cause this guy to have syncope, fall down, and maybe have a head injury as well. More details of diabetic neuropathy are discussed in the diabetes mellitus section. I want to reiterate the fact the commonest long-term complication of diabetes mellitus, 50% of diabetics, if they're not going to take care of their health and their HbA1c values are more than 7%, they're going to end up with development of what I have just described before you, a diabetic neuropathy component. It is irreversible. Once this happens, you can't do much for the patient. Now let us compare the manifestations of acquired neuropathy versus a congenital neuropathy, and the disease that I'm showing now before you is actually called as Charcot-Marie-Tooth disease. In lots of MCQs, because this conventional term is still picked up by most doctors very well, he would like to use an alternative terminology as well. The alternate terminology is HSMN, that is hereditary sensory motor. So the surprising thing that I'm teaching you is that the neuropathy can be congenital as well. The name is hereditary sensory motor neuropathy. And now I will explain to you that why is it important from the exam perspective. If you cast a glance at the image that I've shown, you will notice a very peculiar thing happening here, that the muscles of the thighs look okay, whatever is visible. But when you look at the calf muscles, you will notice a very strange configuration coming up, right? There's rather wasting of the peroneal muscles which is developing in this patient. So lots of time, I can use the word champagne bottle appearance or inverted champagne bottle appearance, or more characteristically the word stork leg appearance. You see, stork is a bird that stands in water in on one leg or on two legs, and it keeps on eating fish. So stork is a bird which has very thin legs, and therefore the word is used as stork leg appearance is one of the reasons why I'm mentioning before it. The reason for this stork appearance is predominantly a presence of a peroneal muscle atrophy in this condition. I want you to contrast this with pseudo hypertrophy of the calf muscles. I hope all of you recall from pediatrics, pseudo hypertrophy of calf muscles is a feature of Duchene's muscular dystrophy. So it is primarily for the image-based question that came. They have given pseudo hypertrophy of the calf muscles also, that I'm going to show you subsequently and explain about it. You can see the pseudo hypertrophy and compare this with the calf muscles of this particular chap, which are going to be almost gone. In the later part of the disease, there can even be contractures developing in the foot of this patient. In fact, some of them might partially be visible as well in the toes. There happens to be contracture because after all the nerves are involved. So the muscles will undergo a lower motor neuron type of degeneration. There would be flaccid muscles and there could be contractures occurring in the patient. Now, whenever you read about thickened nerves, especially in an Indian exam, you always are tempted to think in terms of leprosy, but I'm teaching you congenital neuropathy where you have thickened nerves. Moreover, if you are going to take a biopsy of the thickened nerves per se, the manifestation seen here would be called as a onion bulb appearance. The last time I described a nerve biopsy showing a onion bulb appearance was for a variant related to Guillain-Barré syndrome, that was CIDP, chronic inflammatory demyelinating polyneuropathy. The facts that you need to remember for this particular disease are mainly three. Look at the calf muscles of this patient, almost gone. There would be lower motor neuron kind of a degeneration, so there would be contractures developing in the feet of the person, difficulty in walking, ambulation issues would come, repeated falls would come, difficulty in walking on ice or difficulty in walking on slippery surfaces can be present. And if you do a biopsy, you get this characteristic finding that is going to be an onion bulb appearance. Now we will compare this with a disease which has been taught in pediatrics as well. So I am sure you are very thorough with it. That is Duchene's muscular dystrophy. I'll try to give my inputs here for this particular disorder. And the first one I've already provided to you is that dystrophy is always a progressive weakness. The pattern of inheritance of this is going to be X-linked recessive. So it is boys who are going to be suffering from the disease and girls are going to be carriers and going to transmit it to the next generation, as is the norm for all XLRs. The gene which is going to be involved in this case is dystrophin gene, which is one of the biggest genes that you actually read about. And because of the defect of this gene, there is a defective coding for a protein by the name of dystrophin. Now, problem is that in the muscles you read about proteins like actin, myosin. Where is dystrophin? Dystrophin, guys, is a sarcolemmal protein. So I would call it more of a regulatory protein than the one that is actually doing the job of contraction per se. This is a sarcolemmal protein whose malfunction is occurring at this particular point of time. So the ability of the muscles to perform will definitely be hampered. The age of presentation of this disease would be something like 4 to 5 years of age, and the mother has brought this child over to you because she says, Doctor, my child keeps on falling again and again in the stairs. You thought it is a very overprotective mother. You see, if a mother comes to me and says, Sir, my child keeps on falling all the time, I'll say, so what? No, children keep on falling, let it be. She says, no, sir, when I compare her with older children or with children of even the same age, I find that my child will have to take the support of the railing while climbing stairs. And children, once they grow up and they start in this bipedal mode of locomotion, they love to run around. This kid, she says specifically when the child has to get up from the floor or when she has to climb the stairs, because in climbing stairs, anti-gravity muscles and muscles around the hip joint would be used. So child is having an extreme amount of difficulty and there is recurrent falls also. I initially thought that this is a very overprotective mother. So I told her, okay, let the child play around in my clinic. Like the child was sitting in the lap of the mother. I said, please, let the child be comfortable and let him just move around. When the child started moving around, the mother pointed out that, see, doctor, I have brought him to you because my relatives and my mother-in-law is always asking me to show him to a doctor because when this child will walk, since there is weakness of the muscles of the hip joint, his body will sway from side to side. Like if you look at me, you see the child is walking, but the body is swaying from side to side. On account of this hip joint muscle weakness, there will also be a characteristic waddling gait present in the child. And well, the mother-in-law was right. She was pointing out to the fact that there's something wrong with the walking of the child or the gait of the child as well. What I will tell the mother next will be, ma'am, I request you to please sit on the floor cross-legged. She's totally, taken aback by your request. She says, sir, I'm sitting on a chair. You can't even offer me a chair. You're asking me to sit on the floor. I said, yes, ma'am, I want you to sit on the floor with your child. Because if I ask a 4 or 5-year-old child, no, sit on the floor, he might not listen to me. He might get scared because I am an alien to him and therefore he may not be able to, or I may not be able to elicit some clinical findings. I have now made the mother and her son sit cross-legged on the floor, and then I have asked the mother and the child to get up simultaneously, and I'll tell the mother to encourage the child to get up suddenly. You will notice that the mother will be able to get up because she is herself a carrier, she is not suffering from severe manifestations. But when it comes to a child, guys, it's a 4-year-old child, 5-year-old child, you expect a 4 and a 5-year-old child to get up from the floor by himself, he will not be able to. He might extend his hand towards his mother, expecting the mother to help him, and you will tell the mother, no ma'am, please step back. Don't help the child. Now you will notice this 4 or 5-year-old child, either he will crawl, because you see, like if you are sitting in a doctor's chamber, it may not be very big. So you will notice this 4-year-old kid sitting on the floor near you, he might crawl near to your table and take the support of your table and stand up. Or you will get manifestation like this, where the child will take the support of his arms to prop up and get his body off the floor. And now notice he's using his hand to support his knee joint and then gradually get up. So this is what is classically called as Gower sign and helps you in identifying Duchene's muscular dystrophy very well. I want you to remember the fact that to elicit Gower sign, you obviously need cooperation of the mother as well, because she is to encourage the child to get up, and lots of time, she might intervene in between because she is noticing her child is not being able to get up. So you just need to tell her, ma'am, please step back and let the child perform on his own. This child will suffer from progressive weakness, and most children with Duchene's muscular dystrophy become wheelchair bound by 10 to 12 years of age. So you can imagine now the boy was reaching towards the age of puberty, his weight will start increasing, his muscles of the upper part of the body will start developing, but the hip joint muscles are rather almost gone. He would be wheelchair bound, he might become completely bedridden, and the child might unfortunately expire. If they ask you what is the leading cause of death in this condition, yes, respiratory infections will definitely occur, but the leading cause of death first will be answered as congestive heart failure and then would be answered as pneumonia. So I also want you to remember that cardiomyopathy, you see the disease that I'm teaching you is related to the skeletal muscle, but studies have shown that even cardiac muscles can be involved in this condition. So cardiomyopathy can also be seen in these patients, which is why I explained congestive heart failure and pneumonia in that order as the leading causes of death of these patients. Let us now look at what will we do for the workup of these patients, where the first test that I want you to remember for this condition would be CPK-MM. The only problem is that CPK-MM values may actually be elevated in the initial phase of the illness, but usually by 10 years of age because of muscle wasting. Mark my words there. Once the muscle wasting component will come in, the CPK-MM values might turn out to be normal, and because they will normalize, our educated mother will always ask you, sir, my child is responding to treatment. Because lots of time they might be taking treatment from Ayurveda, homeopathy, and they might say, sir, our child is responding to the treatment. Please appreciate the fact that CPK-MM in this case is turning out to be normal, not because he is responding, it is muscle wasting. In fact, by 15 years of age, there is a possibility that in this condition, CPK-MM levels may be less than normal. The same mother will ask you, sir, report is wrong. You will tell her, no ma'am, it is not the report is wrong. It is simply the fact that the values are significantly reduced because of extensive muscle wasting in this case. So let me summarize. This is what I was saying. The initial presentation CPK-MM values are found to be elevated. When the same patient will be 10 to 12 years of age, the values might turn out to be normal, and by 15 years of age, the child might actually be having lesser than normal. It is because of muscle wasting. Please appreciate why CPK-MM is not the investigation of choice for this condition is because the values can vary with the course of the disease. So if he says, what is the best way for diagnosis of Duchenne's muscular dystrophy, because it is a genetic disorder, remember my words, for all genetic disorders, your answer will be PCR, and in this case, I will be doing a PCR for dystrophin gene, by which I will be able to confirm my diagnosis per se. I want to highlight once again that CPK-MM values will change with the progression of the disease. It does not mean that the child is improving. It is actually that the child is worsening. Coming to the treatment of this condition, we do not have any definitive treatment per se. Those steroids are mentioned in the textbook, but per se they will not alter the change or course of disease. Primarily, a lot of these children would die by 20 years of age, and it's really sad for any parent to lose a child, let me say 20 years of age. Chest physiotherapy can definitely delay the inevitable. I want the muscles of the chest of this child to be in top shape so that at least he can expectorate his lung secretions, and majority of these children are very skinny and have extensive muscle wasting right before their death. I will now be explaining to you a milder variant of Duchenne's muscular dystrophy that is called as Becker's muscular dystrophy. Please remember the fact that there are two separate diseases. One is called as Becker's disease and second one is called as Becker's muscular dystrophy. If he says in the exam Becker's disease, right, then this Becker's disease is actually a variant of what is called as myotonia congenita, and this happens to be a chloride channel defect. I want to repeat this fact once again. There are two terminologies that I'm highlighting at the moment, guys. One is Becker's muscular dystrophy, second is Becker's disease. Becker's disease is actually a variant of myotonia congenita. It happens to be a chloride channel defect. If you're listening to me carefully, I had talked about one chloride channel defect earlier also, that is Thomson disease. I now want to tell you that this Thomson disease and Becker's disease are actually two variants of myotonia congenita. In fact, it would be better if I just go back in one of my slides and mention this fact once again. I was talking about lots of channel aspects, so that is where I had spoken especially about channel aspects related to heart, and I had written this terminology, chloride channel defect is Thomson disease. Just adding to this the word there. In fact, it would be good if you can note with me in the notes also. Thomson disease and Becker's disease are variants of what is called as myotonia congenita and are chloride channel defects, in contrast with what we are studying at the moment, that is Becker's muscular dystrophy, which would be a variant of Duchenne's muscular dystrophy. Well, how is it a variant? The presentation is slightly delayed. In Duchenne's, I was talking about a 4 or 5 year old kid with waddling gait, recurrent falls. In this case, the child will present at 10 years of age. Usually by 25 years of age, he will become wheelchair bound and ultimately will expire either due to congestive heart failure or due to pneumonia at about 40 years of age. Let me just write it down before you so that you can understand the fundamental differences between the two. I said the presentation of Becker's is at 10 years. As the disease will progressively increase in severity, the child or the adult now will become wheelchair bound and then unfortunately will expire. I reiterated this statement because when I'm gonna get CPK-MM values of this patient done, At presentation, they are elevated. When he is having muscle wasting, the values will become normal. And before death, the word is before death, the values can even be lesser than normal. The relatives will ask you, sir, the laboratory has given us a wrong report. No, it is not a wrong report. The values are lesser than the reference range because the patient is having extensive muscle wasting. Well, on basis of this, let's do a question here which will make you understand why am I reiterating this statement again and again. This is how he mentioned 10-year-old boy. He said the child is having ambulation issues, like he has difficulty in playing at school, or he has difficulty in going to the bathroom. So, I mean, the child is having problems with the routine gait. And then he mentioned the child is also having large leg muscles. Like, he did not mention the word pseudo hypertrophy of the calf muscles. He simply said large leg muscles. And the CPK-MM values of this child were given to be normal. Now, because the CPK-MM values are given to be normal, it cannot be Becker's dystrophy, because just now I explained to you that in Becker's dystrophy at presentation, CPK-MM values would be double, triple, 10 times of normal, because the values are given to be normal. Therefore, the diagnosis will be given as Duchenne's muscular dystrophy. If you were listening to me carefully, you would have noticed that in Duchenne's, the values were elevated at 5 years. By 10 to 12 years, when he was wheelchair bound or going towards wheelchair bound status, that is when the values were becoming normal. If in the same MCQ, I'm using a different pen to highlight, if in the same MCQ, if the values of CPK-MM were given to be elevated, then the answer would be given as Becker's muscular dystrophy. And in the same spirit, I also want you guys to remember Becker's disease and Becker's muscular dystrophy are definitely not the same. Becker's disease is a chloride channel defect, and Becker's muscular dystrophy is what we just talked about. That is going to be presenting in identical fashion, identical in a sense that there would be a progressive muscle weakness and the patient will die either because of congestive heart failure or pneumonia or a combination of the two. We will now compare this with the following child who is having one characteristic manifestation, which if I do not highlight, it might be missed by you. You can see that the child's mouth is partially open, and one of the features that is described in the textbook for this particular case, the diagnosis I will give you in few seconds from now, is tenting of the upper lip. The second feature that he might write is myopathic facies, because they would be wasting of the muscle, especially the temporalis group of muscle. Masseter muscle might be having a bit of wasting. So the word is myopathic facies or Hatchet facies. Well guys, the disease that I'm teaching you now is called as myotonic dystrophy. Myotonia per se means that there would be a defective relaxation or slowed relaxation of the muscles. Myotonic dystrophy is actually read by you in multiple other subjects, and I just want to compile that information on a single slide. One, when you're studying ophthalmology, they always talk about cataract being present in myotonic dystrophy. Yes, you got it right, the Christmas tree appearance. So one reason why you have done this MCQ is for the cataract, that would be Christmas tree appearance. Second, in cardiology, when you read in pediatric aspects, cardiac conduction defects, then myotonic dystrophy can come up. It could be heart blocks developing in a patient. With respect to, again, pediatric endocrinology, they teach you that this child could be having type 2 diabetes mellitus. So one, I want you to remember that myotonic dystrophy itself can be of two subtypes, that is type 1 and type 2. And one of the characteristic manifestations that you need to remember for this disease is the ocular aspect, the cardiac conduction abnormalities, association with type 2 diabetes mellitus, with these words like tenting of the upper lip, Hatchet facies, and or the alternative term can be myopathic facies as well. Another term that I want to highlight before I show the images is, instead of saying calf muscle hypertrophy, he might actually describe a disease to you in which the patient is having significant calf muscle weakness. I did not say calf muscle or peroneal muscle atrophy. It was calf muscle weakness which is causing the patient to walk on his toes, toe walking. The question's language will be like this, that he will make it sound like you are reading a question related to, let me say, Duchenne's, or he might make it sound that you are reading a question where there is Charcot-Marie-Tooth disease, but actuality, the disease that sometimes can be asked in the exam, where he will himself mention that the defect in the muscle protein is emerin/lamin. Guys, this is gonna be also X-linked recessive disorder, so found in boys. You can see the question will begin by describing a boy who is having calf muscle weakness to walking present, and if you read the question casually, you might think that it is going to be Duchene's muscular dystrophy, but he has himself given you the information of emerin or lamin protein being defective. These are again sarcolemmal proteins. So when you read the current information that I put in the box given to you in a question, then you are supposed to answer this as Emery Dreyfus. I will just show you a couple of diagrams also to differentiate between the two. But the first and the foremost thing that I want you to be sensitized to is the fact that every time you read about calf muscle involvement, don't jump the gun and think only in terms of Duchene's or in Becker's. Yes, Duchene's and Becker's obviously are X-linked recessive. It's still gonna be a boy. He's still gonna be having problems with walking per se. But just if you are getting the words right, I was not using the word calf muscle weakness for a kid with Duchene's muscular dystrophy. I was talking about hip joint muscle weakness. Calf muscle weakness was never used by me. I used the word pseudo-hypertrophy of calf muscles, and because he knows that we have this bias in our mind that whenever we read about calf muscle, we think it in terms of Duchene's or Becker's, he will definitely try to, bend your mind towards the wrong answer. Whereas you guys are smart people. Obviously, you won't get biased by the examiner's attempts to, make you divert from the correct answer. If you read the terminology that I've highlighted, calf muscle weakness, toe walking, emerin laminin defect, which are again sarcolemmal issues, Emery Dreyfus would be given as the answer. I shall now be explaining these various kind of muscular dystrophies to you on the basis of these images. In fact, in the first diagram that I'll number here, the pattern of inheritance is X-linked recessive, that's a boy, and for the second one is also X-linked recessive. But you will notice small fundamental difference here, which is that in the second diagram, the diagram is mainly pointing towards presence of calf muscle weakness along with weakness of also the arms. This is going to be a presentation of Emery Dreyfus. Whereas now when you compare the fourth diagram with the fourth diagram, you will notice slight subtle differences. The differences are that shoulder muscle involvement is common between the first and the fourth. Thigh muscle involvement is common, but you will notice involvement of brachioradialis and forearm muscles. You will also notice involvement of the neck muscles for diagram number 1, but not for diagram number 4. In fact, this particular disease that I'm pointing out is autosomal recessive in inheritance. Well, I want you to realize the fact that in Duchene's muscular dystrophy, there can also be involvement of the neck muscles. There can be involvement of brachioradialis and forearm muscles as well. But if we will talk about predominantly axial musculature involvement, then you need to think in terms of limb girdle muscular dystrophy. When it comes to congenital myopathies, then almost all muscles of the body can be involved. Patient will be having gross paralysis. So there is nothing much that he can ask you in congenital myotonic dystrophy. What he will usually ask you will be for Duchene's muscular dystrophy versus Emery Dreyfus versus limb girdle muscular dystrophy. And let's look at the last diagram which is given here, which is having weakness of muscles related to the mouth. So in this question, he will definitely talk about weakness with respect to chewing. I have talked about chewing muscle weakness in myasthenia gravis also, but you see in myasthenia gravis, there is always going to be a diurnal variation of symptoms. In this case, one of the manifestations is chewing muscle weakness present in a patient. Then obviously the involvement of the abdominal muscles like rectus abdominis is given. Muscles of the forearm are involved, chest muscles are involved, and one very characteristic manifestation which is not shown in this diagram but I'm highlighting is involvement of the back muscles also. So this person is also having a feature of winging of the scapula, which you normally read in anatomy, but today I'm teaching you a disorder which is called as fascio. In fact, I think most of you would have guessed it by the way I said winging of the scapula, that is fascioscapulohumeral. You can see the arm muscles are also involved, so fascioscapulohumeral dystrophy. So what he has done in the exam is that he has described these various muscle involvements, and then he's asked you to identify. And because this is going to be longest question, so if you get this diagram imprinted in your mind, like I always say, doctors should have a photographic memory, you would definitely be able to crack those longish questions related to especially muscle diseases. I first want you to focus on 1 and 4, because if you will get 1 and 4 right, then remaining things will fall into place by themselves. In 1 and 4, you can see shoulder muscle involvement is common, thigh muscle, hip joint muscle involvement is common, but forearm muscle and neck muscle involvement given, that is DMD. And obviously the gender part will also play a role, but don't rely on gender per se, for solving a question. It has to be this pattern that I've highlighted. And if he says calf muscle weakness, Emery Dreyfus, if he's talking about winging of the scapula, it is fascioscapulohumeral dystrophy. So let me make you practice this information once again so that you get it right. You see, what we have learned is if he describes a question of a boy, gives you information of Gower sign. That is straightforward. But remember, Gower sign in a girl at 25 years of age is dermatomyositis. So don't be under impression the Gower sign is DMD, because if he changes the gender to female, say CPKMM elevated, and then talks about Gottron papules and mechanics hands, etc., the diagnosis becomes dermatomyositis. The traditional information given for the MCQ would be pseudo hypertrophy of the calf muscles, large leg muscles can be written, then it is DMD. I have written here traditional information and warned you about the fact that the moment you read Gower, don't jump the gun and think that the question is always of Duchene's. It can be dermatomyositis as well. If it talks about a boy, but then mainly talks about calf muscle weakness, toe walking, does not give any information about hypertrophy of any muscles, then you need to think in terms of Emery Dreyfus, as I've highlighted. You see, why am I saying it again is just so that you can remember the information. Then it's going to be mainly axial. However, if it describes a question of a boy who's having a calf muscle weakness, the word is not a hypertrophy, it is calf muscle weakness and toe walking, then I have already sensitized you to this. That would be Emery Dreyfus. If he talks only about axial musculature weakness, then you have to think in terms of limb girdle muscular dystrophy. And if he talks about combination of chewing muscle weakness, though obviously if he's talking about diurnal variation, you know it is going to be thought in terms of myasthenia gravis, but chewing muscle weakness and then information of winging of the scapula. You can also remember abdominis, rectus abdominis muscle involvement, so patient will have difficulty in getting up, maybe doing sit-ups, etc. Then we will have to think in terms of facioscapulohumeral dystrophy. I'll just mention the short forms here, that is DMD, then Emery Dreyfus. Limb girdle muscular dystrophy has a lot of variants actually, you don't need to remember all of them. And lastly would be facioscapulohumeral dystrophy. So this is a summary, guys, which I think should be useful for solving questions and are discussed in pediatrics also. To finish this topic, I would lastly like to mention, whenever you read about gradual weakness developing in an individual, you see, whenever you're having a sudden onset weakness, you obviously have to think in terms of Guillain-Barré syndrome, transverse myelitis, botulinism from pediatric perspective, poliomyelitis, or if it is going to be over, let me say 9 weeks or so, we have to think in terms of CIDP, chronic inflammatory demyelinating polyneuropathy, which have been discussed earlier. But overall, when you talk about a gradual onset weakness in an individual, the first thing that you should always do is rule out electrolyte imbalance, rule out hypokalemia. If the weakness is still present, rule out neuropathy by doing a nerve conduction velocity. Evaluate the problem of muscles by doing a CPK-MM as well as a muscle biopsy at this particular point of time. And if it's neither going to be a neuropathy or a myopathy, it could be disease of the neuromuscular junction. So check for the antibodies for myasthenia gravis, which are going to be anti-acetylcholine, as receptor blocking antibodies. It could be anti-MuSK, that is muscle specific kinase antibodies, then LRP4 and anti-P by Q antibodies for especially Lambert eaton. Aiding you in the diagnosis will be repetitive nerve stimulation test, which has been discussed, having a decremental response with respect to myasthenia gravis, incremental with Lambert-Eaton syndrome. Then you will also be running electromyography in the patient, run genetic studies in the individual to pick up possibilities of channelopathies. And myopathic presentation can definitely help you identify that this person could either be having a disease by the name of motor neuron disease that I have discussed separately, or it could be channelopathy. So both of them have to be ruled out. Now, assuming you have ruled out, myopathy, you have ruled out amyotrophic lateral sclerosis, then you also have to think in terms of connective tissue disorders like dermatomyositis and polymyositis, where antibody might aid you in the diagnosis, like anti-Jo1 antibody, and information of Gottron papules or mechanics hands, Scholl sign, those are, or heliotrope rash, those are kind of informations that have been discussed per se for dermatomyositis. In fact, I'll just jot down the names once again. For dermatomyositis, it is Gottron papules, which are always found on the knuckles of the patient. Heliotrope rash would be on the upper eyelid. It will look as if the lady has put on some kind of a makeup. It would be a purplish rash around the upper eyelid. Scholl sign would be reddish rash on the shoulders of the patient. And the fingertips of this lady is going to be like, like a car mechanic, his hands are coming in contact with grease and engine oil. So there would be cracks present on the lateral aspects of the finger per se, so mechanics hands. The message is that if you are getting a question, and I would like to write this separately, if a question mentions regarding asymmetrical distal muscle weakness, now mark my words there, because I've talked about symmetrical weakness, I've talked about asymmetrical weaknesses spanning over years. But if you're reading especially a question which is talking about asymmetrical distal weakness and on muscle biopsy, which is done superiorly, some inclusion bodies were found, then the diagnosis of the patient should be thought in terms of inclusion body myositis. But these are relatively rarer causes, right? So thought process is neuropathy, myopathy, neuromuscular junction disorder, then is channelopathies, then could be connective tissue disorders, then could be even rarer ones like inclusion body myositis. And all of these patients will definitely be having weakness present, not muscle pain. In contrast, if you get a question where is mainly describing muscle pain in, let me say, a female patient, but on physical examination there is no weakness, or the patient himself is not reporting any weakness, then the diseases that you need to consider is one, fibromyalgia, and the second one is polymyalgia rheumatica. In fact, when you will do a lot of questions on this topic of especially a female patient presenting with muscle pain and acute phase reactants elevated, you will notice that the diagnosis will be given as what I'm writing right now. So let me just make you practice this question as well, which will describe a 50-year-old female patient, or it could be male also, but mostly gender wise will be female. When you ask this lady where is the pain present, muscle pain present, she will say that my orthopedician has told me that I have frozen shoulder. So there is stiffness and pain in the shoulder, because of which she has difficulty in working in the kitchen, or she has difficulty in retrieving items kept at a higher place in the kitchen shelves per se. Then she's pointing to her lower back. She says everything hurts, even hip joints hurt, shoulder pain is there. And when you checked her acute phase reactants, her erythrocyte sedimentation rate was elevated, CRP was strongly positive. You have ruled out nerve disease in this patient, so nerve conduction velocity is normal, CPK-MM values are normal, muscle biopsy of this patient is also normal. So then with elevated acute phase reactants and these complaints that I mentioned, relatively in an old age lady, you need to take into consideration, especially gross elevations of ESR, you have to take into consideration the diagnosis as polymyalgia rheumatica. Though it's obviously symptomatic treatment for these patients, but I just wanted to highlight that when you're reading the question, be very sure about the fact that is he talking about muscle weakness or is he talking about muscle pain? Because if somebody is having pain also, even then the ability of the patient to do any tasks will be restricted. So like if I have pain in my shoulder, I will not be able to comb my hair, no? So the point is difficulty in combing in hair per se as given in a question should not prompt you to think that okay, we are talking only about a myopathy. It could even be something as simple as an orthopedic complaint of a frozen shoulder or some kind of an injury which was incurred at the time of sports related activity, maybe in a young male. So you need to read the question to actually understand the kind of perspectives that is asking you, and therefore towards the end I have just tried to summarize. Whenever you get a question on non-specific complaints like weakness, or जिसको हिंदी में पेशेंट बोलता है कमजोरी है जी डॉक्टर साहब, right? कमजोरी word is like grossly used by your patients in outpatient department, then these are the disorders that should come in your mind and you should sequentially be able to rule them out in subsequent visits before you tell a patient that there is nothing serious enough to worry. And this particular diagram, guys, if you can just take a snapshot of it and maybe just revise it a couple of times, this would definitely do you good, especially first and the fourth image in comparison with the second one. I think this particular statement, no winging of the scapula, this I will not find anybody making a mistake along with combination of other facts, but 1, 2 and 4 I have usually seen people making mistakes, especially for emery dreyfus, so I highlighted that even in the earlier part of the discussion. So these are the details, guys, that I want you to study for this topic. Keep learning these facts on a regular basis, and the more you learn, more you upgrade, the higher your mental capacity becomes, the better you will be able to perform in the final exam. And thank you so much for your patience and hearing me out.